All right, to all who are new here, welcome. Due to COVID-19 precautions, we have moved our regularly scheduled journal clubs to an online platform. This is Dr. Michelle Henney of Releve Sports Medicine speaking. Fortunately, our fearless head of the journal club and liaison with the BOC, Brittany, continues to do an excellent job at making this a seamless transition. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. These are all free of charge for you. For all of the athletic trainers intending to get live continuing education unit credits from the BOC, immediately after the webinar, complete the quiz, which will become available once the webinar has finished. So in order to access the quiz, you must remain in the webinar until it closes. 60 minutes after the webinar concludes, you will be emailed a link to the evaluation and assessment. You'll have 24 hours to complete the assessment. Once you've completed the quiz and the assessment, you'll receive your statement of credit via email within 2 business days. If you have any questions during the webinar, please submit those questions and we will review the questions at the conclusion of the presentation. So I am going to transition over then to Dr. Pilkington, a urologist with AdventHealth Medical Group, who is going to be speaking today about genitourinary illness and injury in athletes.
All right, good evening, everyone. Like Dr. Henney said, my name's James Pilkington. I'm a local urologist. Thanks for having me, and I hope that I can provide some useful information. Although, genitourinary illness or injury might not be something you deal with often in your profession, it's something to be on the lookout for and something you might come across here and there. So this is just a little cartoon that I like, but it says, wait a minute here, Mr. Adams, maybe it isn't kidney stones after all, and you have a nice rhino sticking the guy in the back. I have nothing to disclose as far as my presentations go. So the first thing we're going to talk about today is hematuria, or blood in the urine. That's something you might come across, and probably the most common thing you might see in athletes, either microscopic blood in the urine or gross or visible blood in the urine. And blood can come from anywhere in the urinary tract. It could come from the kidneys. It could come from the collecting system or where the urine drains, which includes your renal pelvis and your ureter all the way down to your bladder. It could come from the bladder. In males, it could come from the prostate, or it could come from the urethra. Certain things that you could have causing blood in the urine include ischemia or infarct to the kidney, different kinds of injuries to the kidney, infectious diseases like tuberculosis or pyelonephritis, kidney stones, things like bladder tumors or bladder inflammation, bladder infections, enlarged prostates, urethral abnormalities such as urethral trauma. In athletes, what you'll most probably commonly see is exercise-induced blood in the urine. Like I said earlier, you can have gross or visible urine, or microscopic, or where it can only be seen under the microscope. And you can see this after strenuous activity, and usually this resolves within 48 hours. The strict definition of microscopic hematuria would be if you looked at a centrifuged urine specimen and you saw greater than 3 red blood cells per high power field, that would meet criteria for microscopic hematuria. And the vast majority of your cases in athletes would present as microscopic rather than frank or gross hematuria. When discussing hematuria in athletes, you can generally classify them into 2 different categories. Hematuria seen in contact sports, which is generally caused from direct injury to the urinary tract, things such as football or rugby or boxing. And then your non-contact sports, where you might see blood in the urine from physiologic change, things like running or rowing or cycling. When discussing contact sports, some studies that have looked at this After 150 competition boxing fights, they found that 27% of urine specimens showed blood in the urine, and 3% of these patients had visible blood in the urine. And these are likely from things like kidney trauma. And the hematuria rate after 5 matches in 30 elite rugby players showed a hematuria rate of 24.4%, and then rates following non-contact training sessions were generally around 7.7%. So certainly in these higher contact sports, the incidence of trauma is likely higher, even if it's just microscopic blood in the urine. Certainly if you're combining endurance sports as well as contact sports, you might have kind of both the physiologic picture as well as the traumatic picture of blood in the urine. When considering non-contact sports and blood in the urine, it's especially noted in endurance sports. So exercise-induced catecholamines can cause shunting of blood to the muscles and away from the kidneys, which can result in hypoxic nephron damage and increased glomerular permeability and the subsequent release of red blood cells into the filtrate. Hematuria can be seen in 20% of all marathoners. You can also see in these kind of endurance athletes that you could have bleeding from the bladder, and that's thought to be from contusions caused by the slapping of a flaccid or empty bladder wall against the fixed trigone or the bottom portion of the bladder. So if we're getting urine samples on patients participating in athletic and endurance activities, do we need to be investigating them? Should we be referring them to urologists for the full evaluation? Well, there's no current recommendation for hematuria following sports, although current practices generally would recommend treating them as any patient presenting with hematuria. So some report full workup should be performed in those where hematuria does not resolve after 24 to 72 hours after intense workout, or those with gross hematuria or visible blood in the urine, and especially those with an age greater than 40, because after the age of 40, the incidence of malignant causes of blood in the urine significantly increase. So the most common urologic finding in athletes is actually not hematuria, but it's actually proteinuria. And this is found in 95% of all marathon runners. It's caused by an increased renal filtration pressure causing increased glomerular permeability. And this usually occurs within 30 minutes of exercise and clears within 48 hours of exercise cessation. So in regards to persistent proteinuria, a dietary history can be important. You need to rule out high blood pressure and other renal diseases which could be causing proteinuria. Some labs you'd want to get include a CBC, glucose, and BUN and creatinine. And you may also need to collect a 24-hour urine for protein and creatinine. So some additional urologic considerations in athletes and really anyone of that matter includes things like infections of the urinary tract. You can have just your standard urinary tract infections, which are more commonly seen in females. You can experience patients who have sexually transmitted diseases, things like epididymitis and prostatitis in the males. So in regards to epididymitis, you can have a patient who presents with tender and indurated testicles not associated with trauma. One thing you always have to consider, is this an infection or could this be something more urgent or emergent, something like a torsion? When discussing epididymitis, generally in younger males, you have to think about sexually transmitted diseases, things like gonorrhea, chlamydia. Those are the more common organisms causing epididymitis in younger males. In older males, you think more of urinary tract infections, possibly from bladder outlet obstruction and large prostates. And you need to consider generally your pathogens that generally cause UTIs, things like E. coli, Enterobacter, Klebsiella, those kinds of things. Other considerations in athletes, you need to look out for acute renal failure, especially living in the heat like we do here in Florida. You can have patients or athletes who get severely dehydrated. The most common cause of acute renal failure in athletes is rhabdomyolysis, which can be caused by severe muscle trauma due to extreme exertion or direct trauma. So rhabdomyolysis causes an increase in creatinine phosphokinase, aldolase, myoglobin, potassium, phosphorus, and glutamic oxaloacetic transaminase. And myoglobin is the main nephrotoxin. So you would treat as any other renal failure, but rhabdo can certainly be life-threatening and can lead to fairly significant renal failure that can sometimes require dialysis. So your common causes include exercising in extreme heat without proper hydration, alcohol, and many other drugs, and something called McArdle syndrome or genetic lack of muscle phosphorylase. Other urologic considerations you might see in athletes include urinary incontinence. Potential risk factors can include different genetic factors, certain gynecological surgeries, multiple pregnancies in females, and vaginal deliveries certainly have a higher risk for incontinence than females who have had C-sections. Certain neurologic diseases, bowel dysfunction, pulmonary disease, people who have COPD and are constantly coughing, or smokers, obesity, which leads to increased abdominal pressure, certain occupational factors, teachers, truck drivers, people who tend to hold their urine for particularly long amounts of time, certain recreational activities, and in males, those who have had prostate surgeries either for cancer or BPH. So there's a few different types of urinary incontinence. The first is stress incontinence, which would be the most common type you might see in athletes. It's secondary to pelvic floor muscle weakening, and it can happen with increased intra-abdominal pressure or straining. And then there is urge incontinence, which is the kind of gotta go right now, strong sudden urge, and you just can't make it to the bathroom in time. And this is just a schematic showing kind of the difference. On the left, you can see stress incontinence. If you have any kind of increase in abdominal pressure, things like coughing, laughing, sneezing, straining, that weakening of your pelvic floor allows urine to pass. And then with urge incontinence, it's generally more of a bladder issue. Your bladder just may respond differently to filling, and you can just have sudden strong urges and squeezing of your bladder to where you just cannot hold it in. You can actually have both, and we would call that mixed urinary incontinence. So continence requires an active urethra sphincter mechanism, a compliant bladder, meaning that the bladder is able to stretch and keep or store urine at low pressures despite filling up with larger volumes, and the absence of involuntary bladder contractions. And in regards to stress incontinence, like I discussed earlier, it's caused by either high intra-abdominal pressure or inability to control the pelvic floor muscles. It's more common with high impact sports, things like gymnastics. High impact motions can subject the pelvic floor muscles to forces 3 to 4 times the athlete's body weight. So for example, things like gymnastics, combat sports, horseback riding, and weightlifting. This can even occur in females who have never had children. And this was just a study showing the percentages of patients who had some degree of stress urinary incontinence in different sports. And as you can see, and sorry if it's a little bit small, but trampolining had the highest incidence. But you can also see it in things like gymnastics, karate, basketball, just any of the higher impact sports, you can see that. So in regards to treatment of stress urinary incontinence, it generally involves straight cleaning of the pelvic floor muscles or, quote, Kegel exercises. There's also different mechanical devices or incontinence pessaries or insertion devices that put a little bit of pressure on the urethra if someone's just only experiencing this during, say, intense physical activity. That can be something to consider. And then surgical therapies to treat it. In regards to urge incontinence, generally your treatment has to do with behavioral changes first, things like voiding on a schedule, limiting bladder irritants, things like caffeine, alcohol, spicy foods, very citrusy foods or acidic foods. Weight loss can help with both types of incontinence. Pelvic floor physical therapy can help with both types of incontinence, preventing constipation because any extra pressure like stool on the bladder can cause your bladder to fill fuller quicker. Next, there's medical therapies, things like anticholinergics and beta agonists that help to calm the bladder. And last, there's some minimally invasive surgeries, things like Botox injections into the bladder muscle or sacral neuromodulation, which is essentially a bladder pacemaker. So moving on to genitourinary trauma. So one thing to consider is, you may have athletes who are either born with one kidney or had to have a kidney removed for some reason. And, what kinds of recommendations are there? Should these patients be playing in contact sports or to be taking any extra precautions? Recommendations right now are controversial. Most causes of kidney trauma are related to motor vehicle accidents or recreational activities, and less commonly team sports. Football would be the most common team sport to cause kidney trauma, but rarely does this ever result in kidney loss. Usually athletes or any patients who have renal trauma have full recovery without having to remove a kidney. You should get informed consent from the athlete and or parent and educate of the risk of kidney injuries in sports, however. So if you have an athlete who has a significant trauma to the flank, what might symptoms be that you could suspect renal trauma? Severe flank pain, fractured ribs, or blood in the urine. If this is the case, the gold standard would be to have a CT abdomen and pelvis with and without contrast, also with delayed imaging where the contrast actually would be in the collecting system or the ureter so that you can see if that contrast is leaking out anywhere. There's a grading system for kidney lacerations, and so it just goes through basically a normal kidney, then grade 1, you would have a subcapsular hematoma. Grade 2, you might have a perinephric hematoma with a small laceration. Grade 3, that generally means that that hematoma is larger than a certain amount on cross-sectional imaging. Then grade 4, that laceration is going deeper and can involve the collecting system or where the urine drains. And then grade 5, which is the most severe, could involve damage to the main vessels going to the kidney or essentially a shattered kidney. Oftentimes things grade 1, 2, and 3, those types of injuries can be observed, whereas grade 4 and grade 5, generally you're considering surgical intervention or embolization, where embolization would be the first choice because a lot of times that can save the renal unit. If there's significant trauma and a urologist or a trauma surgeon's operating, generally that kidney is coming out. So any way that you can try and save a kidney is always best. And this just goes over the scale that I just spoke about. And then as far as treatment, like I said, for grades 1, 2, and 3, observation and refraining from any strenuous activity for 2 to 3 weeks, and also re-imaging if necessary, especially in the higher grade injuries. And then class 4 and 5, rarely can you observe. If they're unstable, you generally need to send them to interventional radiology for an embolization or perform surgical exploration. One thing to note also is that if you have renal trauma or suspected renal trauma, oftentimes you're also worried about other types of trauma, intra-abdominal injuries, spleen injuries. Rarely do you just get a genitourinary injury. So if there's a significant enough trauma to cause kidney injury, oftentimes they're already quite sick and have already had a CT scan, and there's other injuries that are often found. So moving on down the urinary tract, you can also have ureteral trauma. This is quite rare in sports. It would most often be seen in a rapid deceleration injury, something like a car accident or something like NASCAR. These generally need surgical intervention with either immediate repair or drainage of the kidney with a ureteral stent or a nephrostomy tube. Moving on down, something we can certainly see in sports is scrotal trauma. Direct testicular trauma, you can see contusions. Those often can be managed with ice and elevation. If you have a patient who is having expanding swelling or severe pain, those patients need to seek medical attention for consideration of possible testicular fracture. Those patients sometimes need urgent scrotal exploration or at the very least a scrotal ultrasound to evaluate for any evidence of a testicular rupture. And so this is an image of a scrotal ultrasound, and on the left you have a normal testicle, and basically the capsule of the testicle is called the tunica albuginea, and in a rupture of the testicle you can have a rupture of that capsule, and you can develop a disruption, and you can have leakage of the seminiferous tubules of the testicle. You can have significant scrotal bleeding, and if caught early enough, those things can certainly be repaired. There are instances where these things can kind of heal themselves, but if it's been a short amount of time since the injury, you are much better off undergoing the exploration and repair rather than someone who's had the testicular trauma a couple days prior. Oftentimes, if you do anything surgically, the testicle is probably coming out, and sometimes you can just observe those and they can heal themselves. So another thing to consider, especially in our prepubescent males, is testicular torsion. So if you have a patient who's having pain and swelling associated with nausea and vomiting, that's acute or rapid onset. And often these patients have high riding testicles, absent cremasteric reflex, and negative Friend sign, which would be a decrease in pain with testicular elevation. That a positive Friend sign is more indicative of epididymitis. This is a surgical emergency. If that testicle is not untwisted and sutured into place within hours, you can have a loss of a testicle. And this is just showing how the testicle can twist. An extravaginal torsion is quite rare. That's really only seen in newborns. Intravaginal torsion is the one that we most commonly see. Another thing I didn't touch on was injury to the urethra. That's something you can certainly see with straddle injuries. bicyclers, or trauma to the groin, especially a patient who's having pain and blood in the urine after some kind of stratal injury. That is something that needs to be evaluated emergently for any evidence of a urethral injury. And another thing that you can see sometimes with trauma is bladder ruptures. Oftentimes, like kidney injuries, you're probably going to have other intra-abdominal injuries if someone has a bladder injury. Oftentimes, for a bladder injury to occur, your bladder also has to be distended. So you have to have significant blunt trauma with a quite distended bladder before you would have an injury to the bladder. But those things can also be surgical emergencies. And I believe that was my last slide, and I'd be happy to take any questions. And again, thank you for allowing me to speak on this subject.
All right, thank you. And while we await questions, because I'm sure there are plenty out there, wanted to say thank you again for speaking on this topic. It certainly is something that comes up. I know when we're going through at the beginning of season with all of our athletes and we're going through all the physicals and reviewing, we come across things like, I've got an athlete with one kidney. What should I be doing? Or let's say someone has had maybe a history of kidney stones. What are the things that I want to be worrying about? So this certainly does become very relevant very quickly in those circumstances. So that's very helpful. All right, so I have. So I'm going to read a few of these questions. I'll start kind of going through them from here. The first one is, how do you know when to refer to send an athlete with a testicular contusion?
Oh, I'm sorry, is that for me, Michelle?
Yes.
Okay, so certainly if there's expanding swelling or significant pain and there was a significant trauma, I would be safe rather than sorry. It's easy enough to get an ultrasound. It's easy enough to make sure that there's no testicular rupture. And if there's delayed management, then it can be, things like loss of testicle, those kinds of things. So certainly, I would say the biggest criteria would be expanding swelling, and the second would just be pain that is just really intolerable.
Okay, so, all right, very good. And how about for renal medical emergencies, how soon ideally should they be seen in the emergency department?
For things like a renal trauma?
Correct.
So if there's severe flank pain associated with blood in the urine, or certainly anything concerning for hypertension, like increased pulse rates, anything like that, they should, really that's quite an emergency. I would say that you would have to have fairly significant trauma for that to happen. A significant blow to the kidneys, associated with possibly even rib fractures, that kind of thing. But any real flank pain, and that doesn't necessarily need to happen quickly, but if someone goes home and they start having blood in the urine, they're having severe flank pain, that's someone who should be evaluated in the emergency room.
Perfect. How common is testicular torsion in sports?
So it generally would not be something that just happens during a sporting event. That is just more so something to be aware of in your prepubescent, pubescent age male athletes, because that's who it's going to affect. And that's probably more of an education point rather than something you would see during sporting events.
All right. If you have an athlete who had scrotal trauma at practice or in a game and did not have any immediate symptoms, what suggestions would you give for things to monitor for when they are at home back in the dorms later that night?
So certainly expanding swelling, severe bruising, things like just change in the appearance or texture, things like increased firmness, just those kinds of things, but especially things like expanding swelling.
Got it. All right. I always tell athletes with a kidney contusion to watch for blood in the urine, but do you always need to refer for blood in the urine, or do you monitor?
So I would say if you have a young athlete who has an identifiable cause for blood in the urine, that it is okay to observe that and get additional urinalyses to make sure that it goes away. If it's something that's persistent, then that's something I would have evaluated by a specialist.
All right, and I've got a few questions here in regards to hematuria.
Okay.
So, and I'll kind of maybe list all of them, and then if you haven't answered one, I'll come back to it. But can you speak to hematuria that's only found on the back end of voiding? So hematuria that's coming on without an injury, without a mechanism. Is hematuria normal in some people in the general population? Or if someone has not had a contact injury, there's hematuria, no other symptoms, what should be, from the athletic trainer's perspective, what should be their management strategies?
So if it is visible blood in the urine, and there's no other identifiable cause, then that's someone who I would recommend a full workup with, especially in our older population, anybody over 40, especially athletes who are smokers, which I know is probably not very common, but painless, visible blood in the urine is the type you worry about. In males, that it has about a 22% predictive value of finding a malignancy. In a female, it's about 7%. And that's in the general population, not in the athlete. I'm thinking more so in an athlete, that it probably is a more benign cause, but any visible blood in the urine is the one I worried about the most. Microscopic hematuria, what I would generally do is if it's someone who's doing an endurance athlete or contact sport and it's persistent after 72 hours of cessation of that activity, then that's something that probably should be evaluated. Nothing on an emergent basis, but something that should be considered.
Okay. One of the athletic trainers here had a baseball player hit in the testicles pretty hard by a ground ball this year. Got him off the field, and he became unresponsive but never lost consciousness. He was very sweaty. Is that potentially just a response of the body trying to regulate the pain?
That sounds like it would be more of some kind of vagal response to the trauma and the pain. Really, even if you had a complete rupture of the testicle, there wouldn't be a significant amount of bleeding or anything like that to cause any kind of hypotensive episode or anything like that. So that was probably more of just a physiological response to the significant pain and trauma.
Right. Are there certain vitamins or supplements that may be known to cause hematuria?
That I do not know off the top of my head. I can't think of any off the top of my head.
Okay.
Well, let me go back. So excessive NSAID use could lead to microscopic hematuria.
In the event that an athlete has direct contact during competition and a testicle rises, do you recommend the technique where the athlete sits on the ground? I'm not sure what this means, and gets picked up and dropped.
I'm not too familiar with that.
Okay. All right. With heat and or dehydration that occurs gradually over successive days without adequate replenishment of fluids, are there any specific signs of early onset for rhabdo developing before the condition becomes a medical emergency?
So I would say oftentimes looking at the urine, if it's becoming very dark and almost rusty colored, that would be concerning. But certainly changes in vitals, things like hypotension or significant tachycardia or changes in mental status would be the biggest things to look out for. But rhabdo in my mind would have to be either a very significant vigorous activity, or sometimes we'll see it in say someone who is found down and has been basically laying down for a long period of time.
Yeah, I agree. Just kind of thinking through these, the most common ones that we are more than likely seeing are going to be those football players at the beginning of preseason, are just coming back to exercise. They aren't appropriately hydrated. They aren't appropriately adapted to the amount of exercise that they're doing, and they have an acute episode of rhabdo, more so than it occurring in a gradual fashion. When people have rhabdo, they've got rhabdo. So it's kind of either there, it's not. So yeah, okay. Are testicular torsion and is testicular torsion becoming more prevalent as male athletes are moving to using compression shorts rather than a jock strap? Other than using a jock strap, are there any things that an athlete should be doing to help protect themselves?
Not that I know of. And like I said, testicular torsion generally isn't going to be something associated with sport. It's just more so something that will just kind of happen. A lot of times it happens at night for some reason when these boys are sleeping. As far as different types of jock straps or compression underwear, I don't believe there's any kind of association with that or any certain risk factors as far as testicular health goes.
Okay. So there's some discussion about the PPE in terms from your perspective when people are going through and having their pre-participation exam done. What are the most critical things that you would want to know about as far as these people's medical history?
So, I think certainly someone would disclose whether or not they had one kidney, if they've ever, say if they were born that way, or if one had to be removed as a young kid or anything like that. That would be something I would want them to disclose, which I'm sure they would come up front and disclose that. Another thing to consider is the boy who only has one testicle, say it was either had to be removed for something like cancer or it was undescended, that kind of thing. That's someone who should be counseled and also someone who should be wearing protective gear or a cup. Otherwise, I think that just part of any physical exam, especially in in our college age athletes, discussing things with males like testicular self exams, and in these athletes, safe sexual practices and that kind of thing. I would say those are the most important things from a urologic perspective.
Great. Great. And an extension from that, you were talking about protection if they only have one testicle. What's your perspective on if they have one testicle, one kidney, exclusion from collision or contact sports, talking to them about wearing protection and then continuing with contact sports, maybe suggesting that they move away from contact or collision sports and go to other non-contact sports? What's your thought process there?
So I think it has to be just a third discussion between the athlete and the provider. I don't think that they should be excluded. Like I said, renal trauma would be extremely rare. You have a better chance of losing that renal unit from a motor vehicle collision than from any kind of contact sport. I think things to mitigate the risk in football, wearing like rib pads is important. I'd say that, I would even recommend, for all males, one testicle or two, things like baseball, wearing, protective gear, things where there's higher risk of that kind of trauma. But if a patient only has one testicle, those patients should consider wearing protective gear even in the sports where generally someone might not wear it.
Perfect. Is there jumping back to if someone's having an acute testicular related pain, is there a certain position that they might be able to recommend to help to relieve some of that pain that they're experiencing while they're awaiting further, either while they're monitoring or while they're awaiting further medical evaluation?
So in general, for things like contusions, it's sort of your typical RICE method. So rest, ice, elevation, and compression can also help. So certainly in the meantime, those things can be beneficial while you're waiting for evaluation, or if you're fairly certain you don't have a serious problem, but you got hit pretty good there, then those methods are always helpful.
And correct me if I'm wrong, I believe there may be a sling.
I don't know of any particular sling or anything like that. I usually just would recommend, a good compression type underwear.
Okay. All right. And okay, so there was some clarification in regards to the examination technique. So the athlete lays on their back, the athletic trainer picks up the back of their knees and gently bounces their butt on the ground. I've also, and it looks like there's a couple of people talking about, in regards to testicular contusion, this being a physical exam technique, lifting the athlete and dropping them, whether it's an exam technique or a way to treat.
So I'm not familiar with the maneuver, and the main physical exam techniques that I would consider are just palpation, and then the other kind of sign which generally differentiates from a torsion versus an epididymitis is the friend sign, where you're actually elevating the testicle. But a lot of times on exam, it's going to be tough if there's been a significant scrotal trauma for you to do. If you can't feel the testicle, then that's certainly concerning for something like a hematocele or blood surrounding the testicle, that kind of thing. Or if you just have a very rock hard, firm scrotum, then those are also concerning exam findings.
So there's one somewhat related to that. So if I have an athlete coming in and they're telling me that they have some kind of lump or bump that develops, is there any way that I'm going to get them over to a physician for additional evaluation? What kind of things can I tell them in the interim?
So for lumps and bumps, by far the gold standard would be to get a scrotal ultrasound. That's going to rule out any concerns for testicular masses or cancer, and differentiating that from things like a hydrocele or epididymal cysts or spermatoceles, that kind of thing. But if you're having someone coming in, even not necessarily with trauma, your best friend as far as evaluating the testicle and scrotum is going to be a scrotal ultrasound.
Perfect. All right, and someone's asking for clarification in regards to elevation of the testicle. So you were saying that elevating the testicle will help to relieve testicular pain, and they're looking for some clarification.
So the friend sign is, say you have a patient who, and it's not related to trauma, and you have someone coming in with severe testicular pain, and it's not 100%, not even close to being very sensitive or specific to one or the other, but generally a friend sign would mean that a positive one would be if you elevated the side or the testicle that was painful and the pain was improved, then that's more indicative of an epididymitis rather than a torsion. But regardless, your exam findings are only just going to be, like I said, they're not fully sensitive or specific. The ultrasound is going to be the most important thing to distinguish an epididymitis from a torsion, where a torsion would show no blood flow to the testicle, and an epididymitis would have generally increased blood flow to either both the testicle and the epididymis, but certainly would show blood flow to the testicle itself.
Perfect. Perfect. And that looks to be all of the questions here. So I'm going to say thank you again very much, and thank you to everyone who has participated. We have our next journal club is going to be next week, so you're welcome to continue to follow along with us as we are providing all of these continuing education opportunities for athletic trainers. And thank you again, Dr. Pilkington, for your time.
Thank you all very much.